and the president of, currently he is the president of Mongolian Society of Cardiology. Today, he wants to give us a talk about the assessment of severity of mitral stenosis and mitral regurgitation by cardiac imaging. Professor Mongo Chime, please.
It's me.
Yeah,
hello,
great to see
everybody.
you.
I'm honored to be here. Okay, I'm going to share my screen. Okay, shall we go? Yeah. Ladies and gentlemen, good afternoon. Thank you very much for this Professor Jun Lee and Professor Rongbin Shu and their co-chair in organizing committee for the given opportunity to attend this wonderful webinar. I'm going to talk about the mitral valve disease imaging assessment today. Okay, valvular heart disease are constantly increasing over decades. This study on valvular heart disease, a global burden during involving 1990 and 2017, published on Journal of Global Health on 2017. Here, rheumatic heart disease, still common incidence, is not declining, and moreover, non-rheumatic valvular heart disease is increasing over decades. The incidence of non-rheumatic degenerative mitral valve disease increased 2.15-fold from 1990 to 2017. One of the latest and comprehensive study conducted in regard of presentation in the management of valvular heart disease is a result of Euro Observational Research Program of Valvular Heart Disease, second survey, in which enrolled more than 7,200 patients from 222 centers of European countries in 2017. According to this observation, severe native valvular heart disease was present in 72% of total enrolled patients, and of which 4.5% with the mitral stenosis and 21.3% with the mitral regurgitation. Among mitral regurgitation, 67% were with the primary mitral regurgitation, and 33% were with the secondary mitral regurgitation, of which almost more than half, actually 52%, was classified as having ischemic mitral regurgitation. Among mitral stenosis, main cause is still rheumatic heart disease. Among non-rheumatic valvular heart disease, two most common the disease is calcific aortic valve disease and degenerative mitral valve disease. In regard how the patients were managed with valvular heart disease according to the guideline, percentage of the patients with a class 1 recommendation for intervention in whom was scheduled or performed for aortic valvular heart disease was approximately even more than 80%, aortic valve disease, approximately or even more than 80%. However, with the mitral however, much less patients were managed according to the guideline in with the mitral valve disease. This showing that there is still worrying trend of many patients being referred late in the natural history of their disease for consideration of surgery of transcatheter treatment. Based on this data, guideline was issued by European Society of Cardiology and jointly with the European Association of Cardiothoracic Surgery in 2017. According to this guideline, patients with valvular heart disease needs more complete evaluation. And echocardiography is the key technique used to confirm diagnosis of valvular heart disease as well as to assess its severity and prognosis. And it is also key to assess valve morphology and function, as well as to evaluate the feasibility and indication of specific intervention. This is modified table of imaging, the whole imaging of for mitral valve disease from American Journal of Cardiology in 2018, published by Professor Wenderling and his team, summarizes imaging tools used in mitral valve disease. So the TE, in general, echo and TE, the transthoracic echo, TE, and the 3D TE, and MRI are more for more advantageous for functional and volume assessment, while CT is advantageous in anatomical evaluation. This is a mechanism of development of rheumatic mitral stenosis versus degenerative mitral stenosis. You can see development of the long-term inflammation after single or multiple episodes of rheumatic fever can lead to valve dysfunction in untreated genetically predisposed patients. Leaflets are getting thickened stiff due to the high degree of fibrosis, while in degenerative mitral stenosis occurs in all the patients with the progressive endothelial disruption with the progressive inflammation leading to thickened both leaflets with the restriction of motion and calcification of the annulus. So this is the order how to assess by cardiac imaging. We have to first distinguish pay attention on anatomy and function of mitral valve. Etiology and mechanism is very important. Severity of assessment, including qualitative, semi-quantitative, and quantitative approach, and prognosis and timing of abnormality development, whether it's acute or chronic. Anatomical features of a different type of mitral stenosis is summarized here in this table. We go by one. In anatomical and functional assessment of mitral stenosis, several scores are available for evaluation of mitral valve morphology. And all these scores consider valve thickening, mobility, calcification with a subvalvular chordal fusion. Collecting scores from each category summed up with the score. Here, the example is the presented the abnormality scored with the 8 score. For anatomical and functional assessment, short axis view in 2D and 3D valuable in order to see commissural fusion in rheumatic mitral stenosis here, and open free commissures in red arrows showing the free commissures in degenerative mitral stenosis, and the single leaflet in congenital mitral stenosis. In the left, we see the 4-chamber wave of echocardiogram shows a thickened mitral valve in the tip, which reduced motion and doming during the diastole. Right, the left atrial enlargement. Also, we see the right and left atrial enlargement here. And in the right, we see the thickened both leaflet with the calcification of the annulus. In short axis view, demonstrating doming of the mitral valve here, and fibrotic in the right, calcific mitral posterior leaflet, and with the annulus, small annulus calcification in degenerative mitral stenosis. For severity grading, need to use as much as possible methods. Planimetry, pressure half time, mean gradient, systolic pulmonary artery pressure are the main robust methods. PISA and continuity equation are more complex in mitral stenosis diagnosis and depends on other conditions like existence of mitral regurgitation, etc. According to ESC and ECT's guideline 2017 states that valve area using planimetry is the reference measurement of mitral stenosis severity, whereas mean paravalvular gradient and pulmonary pressures reflect its consequences and have a prognostic value more. Planimetry measurement in 2D, careful cut of ultrasound by edge to edge of leaflet in order to define the least opening areas is the most important factor. Tracing by inner edge in a short axis weave in a zoom is another requirement for accuracy. You can see rheumatic is here and the degenerative is more similar features here. Professor Zamorano and his team in the study demonstrated that compared with all other echodoppler derived methods, 3D planimetry had been best agreement with the invasively determined mitral valve area. So the 3D planimetry in phase wave can show us more realistic area definition of the opening of the mitral rheumatic mitral stenosis as well as degenerative mitral stenosis than 2D images. Here we see the severe rheumatic mitral stenosis, how it looks like in the 3D, and while the degenerative mitral stenosis in 3D as well. And not the qualitative assessment, the pressure half time and the mean gradients. Pressure half time is the must-use method in a mitral stenosis. Here you can see the mean gradient can be estimated by tracing transmitral flow in continuous Doppler, and also pressure half time as in the continuous Doppler as a slope estimation. All these above mentioned methods is reflected in severity classification using above methods. While mitral valve area less than 1 centimeter square, mean pressure gradient above 10, pulmonary artery pressure more than 50, 60 considered to be finding for severe mitral stenosis sign. There are pitfalls in 2D parasternal long axis view. Short axis planimetry accuracy is one pitfall. If cannot be the captured image edge to edge, then it will be falsely estimated. In case of severe calcification, it is also difficult to estimate the area. And in regard of the pressure half time, it is too sensitive method, and false in aortic regurgitation, presence of aortic regurgitation, left ventricle compliance dependent. That means that during diastolic dysfunction, it is overestimating the severity. Falls in immediate after valvuloplasty in a concave shape, making it difficult sometimes, and degenerative calcific mitral stenosis due to the diastolic dysfunction is limiting the usage of this methodology. While the mean pressure gradient has also own limitation, dependent on heart rate, dependent on cardiac output, exercise, volume load due to mitral regurgitation, and all these methods are influenced by atrial fibrillation. In this case, in case of the patient with atrial fibrillation, we have to take several the cardiac cycles and get the average one. CT can be complementary assessment tool in order to evaluate the localization and extent of mitral calcification in annulus, in other in vessels, and also myocardial wall. And also multi-detector raw computed tomography is started to use in order to allow thorough assessment of valve morphology, quantification and regurgitation, optimization of timing of intervention, and device selection in the procedural planning. Here, example of pre-procedural multi-detector computed tomography analysis using 3 major valve software, MDCT, reconstruction for pre-procedural evaluation of mitral valvular anatomy, determine feasibility of TMR. In mitral regurgitation, here is a well-known Carpentier classification modified, where the type 1 is normal, and the type 2 and 3 are due to the primary lifted abnormalities, while type 3B is belonging to the functional or secondary mitral regurgitation. And secondary or functional mitral regurgitation is categorized type 3B, plus there is a mitral regurgitation due to systolic anterior motion in hypertrophic cardiomyopathy belongs in this secondary PMR. So according to the mechanism of mitral regurgitation needs to be assessed well in different type of mitral regurgitation. In rheumatic, more fibrosis which is leading defect of coaptation are major issue, and DMUR Valve motion are the main issue in mitral regurgitation due to prolapse. It's excessive motion of the leaflet, and in functional mitral regurgitation, annular enlargement and geometry of left ventricle and dilatation are the major the mechanism of disease. The grading of severity of mitral regurgitation should be done using all these methods. We go through it. Here, 2D and 2D color useful first qualitative assessment of existence of mitral regurgitation. In T, more accurate assessment of the leaflet motion and coexisting abnormalities. And the 3D in the 3DT is accurate in diagnosing prolapse of proportion of the leaflet, portion of the leaflet, also identification of the leaflet motion in degenerative mitral regurgitation. More advanced 3D, the rendering technology is started to use. With good image acquisition, it can provide easy referring image and clear understanding of mechanisms. Comparison of three types of rendering technologies used in the three cases. The first row and in the top, it is showed the segmental loculated prolapse of P1 in the B-lobe with P2 prolapses. In the middle row in the panel, case 2 showing large P2 prolapses here with the different technologies, and with involvement of the P1 prolapse. In the bottom, the case 3, which is showing P1 and P3 prolapses, shadowing and transparency improves the delineation, here delineation in the scallop borders and the malcoaptation. Also, it is useful to use 3D rendering technologies with the transparency, with the color mode, can more easily demonstratively illustrate the vena contracta flow convergence really in a good way. In regard of the qualitative assessment, two more methods is still available, which is the flow convergence jet and jet density in a mitral valve, mitral regurgitation jet density in a continuous wave spectrum. In regard of the semi-quantitative assessment, vena contracta, systolic pulmonary vein flow are most common tool. In severe mitral regurgitation, we see wider vena contracta and reversal flow in pulmonary vein. In this study, delivers cutoff value of severity for vena contracta in 3D in patients with the different types of mitral regurgitation. For moderate mitral regurgitation, 0.3 can be the cutoff value for functional mitral regurgitation, and almost same for degenerative mitral regurgitation. However, for severe mitral regurgitation, cutoff values are different. In functional mitral regurgitation is 0.52, while degenerative mitral regurgitation it is 0.62. In regard of quantitative estimation of severity of mitral regurgitation, PISA is useful, is usual the method for identification of error and regurgitant volume. Error, the effective regurgitation orifice in severe mitral regurgitation more than 0.4 considered to be severe, and the regional regurgitation volume is considered to be severe more than 60 milliliter. Why it is important to measure error more precisely is error itself is serving as a prognostic value for patient prognosis. So those with the error more than 0.4 have a much worse prognosis in 5 years, we can see here. In addition to all above assessment of functional mitral regurgitation, need to check a left ventricle geometry, mitral or exact area to avoid after procedural stenosis, and presence of atrioceptor defect, PA4, and pulmonary hypertension. In assessment of mitral regurgitation, there are a number of challenges. Eccentric jet, one of them, makes a difficult estimation by PISA, and a multiple jet, another concern for many, as it can be through multiple and also semilunar orifice with the mitral regurgitation presentation in a commissural wave and a late systolic mitral regurgitation. And the distinguishing moderate to severe mitral regurgitation is challenging situations. In conclusion, imaging assessment of mitral valve is always should be done in correlation with clinical features. Echocardiography plays the key role in diagnostic and risk stratification concerning the timing of intervention in valvular heart disease. Assessment of mitral valve apparatus requires an integrated approach involving multiple weaves of transthoracic, transesophageal, 3DT, stress echo methods, and other imaging tools. Quantification of severity of mitral regurgitation should be performed using qualitative, semi-quantitative, and qualitative parameters, all of them. Always assess commissure and subvalvular apparatus, annular dimension, calcification. If need be, CT and KMR can be complementary. Left ventricular size, function, left atrial volume, systolic pulmonary artery pressure, TR, right ventricle functions are important additional parameters of mitral valve, mitral regurgitation consequences. Thank you very much for your attention.
Yes, many thanks, Dr. Monko-Chime, about your excellent talk about the assessment of mitral valve disease, including the CT, the echo, and the MRI. Any questions from all our speakers?
Thank you, Dr. Taka, for your excellent lecture, covering all aspects of the echo evaluation of the mitral valve disease. And in case of the functional MR, because I now doing the procedure with the mitral clip for functional MR patient, the gradient of the MR is very dynamic. It increases and decreases by the volume status or other blood pressure or other things. Then how can we accurately define the degree of the MR in functional MR patient? You measure it in with the full dose diuretics or in normal situation with the in real life. What would be the accurate measure?
Yes, as functional mitral regurgitation is a common disorders in our practice, and the assessment methodology is more or less same as I went through in assessment of mitral regurgitation. We should include all the qualitative, semi-quantitative, and the quantitative methods, all of them. On top of that, we have to consider the size of left ventricle, part of left atrium. If need be, MRI can be a wonderful tool to assist in decision making. That's my answer. Did I answer your question?
Yeah, you know the assessment of functional MR in clinically is very difficult, even for the surgeon. When we decide to do the surgical repair for the functional MR, we have to look at a lot of things, both including the clinically and the imagery and a lot of things. So it is very difficult. Yeah. Any other question?
Agree, yes.
Okay, thank you, Dr. Monko-Chime. Now we have to proceed to the next topic. Our next topic will be provided by the Dr. Jawa Akasia, the professor of cardiology. Currently, he is the associate director of National Institute of Cardiovascular Disease. Today, he wants to give a talk about decision-making in the management of rheumatic heart disease. Dr. Shia, please.
Thank you very much. Can I share my slides?
Not yet. Yes.
Yeah. Right.
Thank you very much, organizers. Am I audible to all of you? Am I audible to all of you? Yeah.
Good.
Yes.
Thank you very much, organizers, for this invitation. And on behalf of Pakistan Cardiac Society, I thank you all for giving me opportunity to discuss this problem, because this is a third world problem. I am especially touching this mitral stenosis, which is big problem in our area, because rheumatic heart disease is a problem of third world. So this my talk is about decision making management of rheumatic mitral stenosis, mitral regurgitation, whether PTMC, mitral valve reconstruction replacement. This is a topic I'm going to touch, and I'm very thankful to Dr. Dagvia for her nice presentation, which make my task easier for discussing in details the imaging section of the problem. Basically, this is a big problem, at least in our area in Pakistan, because we encounter a lot of these patients who presented in development age or in adult age, which is affected by rheumatic mitral valve disease. Less likely we see other diseases like this mitral valve prolapse and MR. So we encounter these degenerative valves. While discussing to our surgeons, when they do a lot of valvular replacement, they discuss these cases and say this is a big problem when you are dealing the degenerated valves. So to start my presentation, I just have few slides regarding which we are just refreshing our knowledge from our medical schools, that what's going on. Basically, normally the blood comes in left atrium and left ventricle, everything is fine. Once this outflow decreases in the size, there are two kind of problems created. Number one, there is problem related to low cardiac output and hypocontractile or hypoplastic LV, which ultimately leads to low cardiac output, easy fatigability. Patient can have symptoms of the syncope, and certainly the back pressure which develop in left atrium ultimately leads to pulmonary venous and pulmonary artery hypertension, which is a cause of shortness of breath, and ultimately increase in left atrial pressure, left atrial geometry, which leads to rhythm problem, particularly atrial flutter and atrial arrhythmia. And this LA, large LA, enlarged LA is harbinger for thrombus formation, which is its deadly consequences later on. So, so these are few major symptoms which patient can present in stage D mitral stenosis. There is severe symptomatic mitral stenosis, which includes difficulty in breathing, fatigue, sometimes chest pain, shortness of breath, and if it's a patient presented with suitable anatomy, as in previous section we have seen that in mitral rheumatic heart disease, sometimes you can't find suitable anatomy. And what is suitable anatomy, we're going to discuss later on in my presentation. Then this PTMC, percutaneous transvenous mitral commissurotomy, is indicated as a class 1 indication. So these are guidelines presented in September 2017, where PTMC can be considered in asymptomatic patient, because mitral valve intervention usually we do in symptomatic patient, but certain class of patient who are asymptomatic, this intervention can be considered. Who are those patients? These include high thromboembolic risk, which have a history of systemic embolism, dense spontaneous contrast in LA, and new onset of paroxysmal atrial fibrillation. Number one. Number two, high risk of hemodynamic decompensation if any person has need for major non-cardiac surgery or desire for pregnancy. So this is challenging one. And sometimes we can see the stage C, which is low gradient MS, but that can be unmasked by exercise or small exercise in our even at clinics. So it's a low gradient mitral stenosis, but unfortunately it is masked when patient do exercise, then gradient increase, and again PTMC or PMC is feasible. If anatomy is feasible, then patient must go for this intervention. Now, the problem in decision making in mitral stenosis before and in pregnancy. We all know rheumatic heart disease predominantly affect mitral valve, and usually the female sex is more prone. In the area where we reside, I reside, there is a usually sometimes patient do not have any problem and they first diagnose during the first or second trimester of pregnancy, but patient doesn't have aware of this problem. So we encounter a lot of these kind of patients in their second or third trimester where they have pregnancy, where they have atrial fibrillation. Now the problem with anticoagulation and whether you go for this procedure, because radiations, we all know that PTMC is not without radiations, and in cath lab there are a lot of radiation. So usually we avoid doing this procedure in first and in second trimester. But yes, we do lot of these procedures in third trimester. And this is a case series which we have published in 2009. 30 pregnant patient with critical mitral stenosis in their third trimester. And I must say it's very challenging because patient, how patient can lie, then you have to cover her with all lead aprons, and you try to minimize fluoro time. And we all know that viscera are not at same position once they are being pushed by this uterus. So puncture is again challenging in these kind of cases. But we see these kind of patients a lot of time. Another difficult situation when mitral stenosis and coronary artery disease coexist. So as we all are aware that any patient who is going for this procedure after 40 years of age, then they must undergo coronary angiogram. And we found not very infrequently patients who has coronary artery disease simultaneously with mitral stenosis. And first case we did in 2008 and published that PTNC and angioplasty at same setting, though there is a lot of room for discussion here that when to give a which procedure should we do first. So but fortunately this was successful case, and few cases we also did afterwards. But still there is a thought, or some people usually criticize it, that don't do it simultaneously. But we all know that we all learn from our practices. So it's a debatable topic. Now, what in real life replace the damaged gate? So if we just, so what is the rule of thumb? Anything which is damaged, you have to replace it. But repair or replace, then it's very difficult, because we know that replacement has certain its own problems, and repair has again some problems. So surgical option 1, 2, 3. There is mechanical valve implantation, bioprosthetic valve implantation, or mitral commissurotomy, but it's obsolete in these days because of this percutaneous procedure. But we still following these patients. 15, 20 years back, they had mitral commissurotomy. They are doing well. They are doing well. Again, there are different type of mitral commissurotomy, open and closed. They have their own details. So this picture will is showing what options the presentation of same which I have discussed in previous slide, that what options we do have and where we should go with which modality. Now decision making is important. You have to sit with the patient and say what's best for her or what best is for him. So putting a mechanical valve is durable. It has very long life, We are seeing following patient who has 20, 30 years, but they are doing well. Then good relief of symptoms, good opening of mitral valve. That basically has also with tissue valve as well. But problem is lifelong anticoagulation and regular INR testing. It's a major surgical procedure. This slide looks very simple, but you can talk minutes and hours on this because this is very tricky, very complex, very challengeable situation. You can see because you are dealing a drug which has a very narrow therapeutic index. Number one challenge. Number two challenge, this drug is notorious for drug interaction for a number of drugs, not only drugs, but number of food items as well. And unfortunately, you're dealing with the population who is not very educated in this area. It's written 2 to 3 INR, some people, but guidelines 2.5 to 3.5 upper limit in mitral area. But it's really challenging practically if my colleague has experience of running or supervising INR clinic, which I do have in my hospital. So it's very challenging. But we are praying that this NOACs, DOACs, whatever is new drugs, have some indication. These kind of still not, but I'm hoping that if some indication emerge, then life become easier. But still, we are going with warfarin. This bioprosthetic valve, definitely good relief of symptom. The problem with bioprosthetic is it has redo surgery is required after 10 to 11 years. But good thing that patient can complete her family if it's a reproductive age. No anticoagulation is required. But problem is they degenerate within 10 years, 10 to 15 years. Now, decision making in mitral commissurotomy. It centers with high level of expertise may have better long-term outcome who are going and undergoing PTMC, but there is a risk of embolic events. If you, as my colleague said, if you have properly non-invasively tested, then these risks can reach up to less than 2% or less than up to 0. But it's again an invasive procedure. And in my center where I work, we usually do these kind of procedures around 400 to 500 procedures per year. So this is New England Journal of Medicine and Circulation. They both have studies have shown that randomized trial have shown established the safety and efficacy of PTMC as compared with the surgical close and open commissurotomy in patient with favorable valve morphology less than 2+ MR in absence of LA thrombus. So this is really an effective procedure. These are recommendations at multidisciplinary and heart valve team and heart valve center. The patient with severe valvular heart disease should be evaluated by multidisciplinary heart valve team when intervention is considered. And consultation with or referral of primary comprehensive heart valve center is reasonable when treatment options are being discussed. Asymptomatic patient who have benefit from valve repair versus replacement, and patient with multiple comorbidities. Now, again, in real life, we replace the damaged gate, we have discussed earlier, but repair is also a cost-effective and time-buying option if we want a palliation of the patient. This is a busy slide where we can see the Wilkin score. There are 4 components of mitral valve are being considered in this. That is mobility, thickening, calcification, and subvalvular apparatus. So 4 is the minimum number, 16 is the highest number, and where we think that PTMC can be effective and complication-free when this Wilkin score is 8 or less. So long-term follow-up studies are available in literature which have shown 70 to 80% of patients with initial good results after PTMC to be free of recurrent symptoms at 10 years and 30 to 40% are free of recurrent symptoms at 20 years. These are the few images, the options available we have. You all are familiar with these two, definitely. This is NOA, this is double balloon, there's a Bonhoeffer technique, and this third one is metallic valve, which I've seen in my resident time. This thing is being used in low-income countries because it's a reusable, it's a Krieger metallic valve, but there are a lot of problems with this device. So again, in this procedure, challenge is a septal puncture, which sometimes is very difficult. And you can go into the aorta, you can go into the pericardium, and there are a lot of issues, but with good practice or backup, surgical backup, things are quite under control. So these are multiple techniques. Sometimes you have to go with reverse loop, or normally, we exclusively 90-95% use this InnovaWell, and sometimes this Bonhoeffer one we stuck, and this procedure is not successful. These are few pictures where relating to the geometry of mitral valve, few people are really convinced opening this valve with double balloon is more effective than NOA. Then there are certain contraindication to PTMC when valve area is more than 1.5, and when there is a LA thrombus and more than 2+ mitral regurgitation, severe bicommissural calcification, that's Wilkin score, is more than absence of commissural fusion, and severe concomitant aortic valve or severe combined tricuspid valve disease or concomitant coronary artery disease requiring bypass surgery. So this is a flow chart. This is a flow chart where we can see that any severe mitral stenosis area less than 1 and their geometry is anatomy is supporting to mitral will then go PTMC. And if there is a problem, high Wilkin score, then you have to go, you have to opt other treatment options. In management of clinical significant mitral stenosis, there is no symptom in high risk of thromboembolism, exercise testing. If there is no contraindication, then go for PTMC. And if there is a contraindication or unfavorable characteristic, then PTMC surgery is another option. So after looking at all of the data, what I think its conclusion of my presentation is symptom, including functional class, has crucial importance in decision making in management of mitral valve disease, and other modalities, including non-invasive imaging, complement our decision. And this is a picture where I work. This is the biggest center in the Pakistan, and I take opportunity to say something about my institution. This is where we are working at world's largest primary PCI center. This network of hospitals is 10 hospitals in different areas of our province. This is the biggest, and other 9 hospitals. And we did approximately 9,000 primary angioplasties in 1 year before COVID in these centers. And with this, again, I thank you all for your patience listening and inviting Pakistan in this meeting. Thank you very much.
Thank you, Professor Sears, for your excellent talk about the management of rheumatic heart disease, especially the PTMC. You do have a lot of experience of PTMC in your country. Any questions from all the speakers?
Yeah, Dr. Shu, just want to ask Dr. Shall we also do PTMC in the Philippines? I'm Dr. Estacio. I'm from the Philippines. Do you go as high as a valve score 9 or a 10 doing, or what is your cutoff valve score when you do PTMC?
Valve score, basically
Yeah.
what we follow the two different area. Number one, height of the patient in this Inouye balloon. There's a data that height of person in centimeters divided by 10 plus 10. That's
10
a simple
plus 10.
rule we follow. And
For
usually
the scoring system, yeah.
for the
The scoring
system,
system for the valve.
for the scoring system for the valve, and the rough area, we want to increase the valve area up to 100%. Say, for example, we are dealing a patient whose area is 0.8, and we will be more than happy if her or his area after procedure come 1.6 or 1.7.
Okay. Just to share, we do not as many as Dr. Shal, but I think 3 or 4 PTMCs a week. We normally don't get, we're happy if we get a mitral valve score of 7 or 8. So everybody's going to be happy. But most of the time we get, it's a socioeconomic problem, rheumatic mitral stenosis, valve score 9. So what we do is, just as long as the subvalvular is not severe and the calcification is evenly distributed, then we normally push for the PTMC. And if it's a high valve score, as we call it, we normally target 1.5. If you get about 1.5 and above, then you stop. Some operators, if you don't still have the MR, even if it's mild, they still push it. So sometimes it's a problem. And for the other, may I just share for PTMC and coronary artery disease? Fortunately, we have not seen these patients, but normally I think what you should do, if your coronaries are amenable to PTMC, what we normally do is do the transeptal puncture first, because after the transeptal puncture, that's when you're going to give your heparin, then leave the coiled wire inside the LA, proceed with your PCI. After your PCI, then proceed with your PTMC. Pregnancy, pregnancy. We try to not do it at the first trimester. I agree with Dr. Shal. It's a terrible problem because you're taking looking after the mother and the child. So if after 26, 28 weeks, you're still in functional 3, then we bring this patient to the cath lab and we do a PTMC. If we can get a moderate mitral stenosis, maybe a 1.3, 1.4, not up for a perfect valve score, which can just tide over the mother for delivery, then we stop the procedure. We only have about 10, when I was a fellow, that was ages ago, 10 series of pregnant persons. We had just one mortality. We had a severe MR, which we were not able to save, both unfortunate. But we do normally PTMC for the second, third trimester. But if this patient will benefit with medication, I guess you should push for medication until delivery, just assisted second stage, and do the PTMC after the baby is out. Yeah, just my thought.
Thank you.
Great. Any other question?
I'll reserve my rheumatic question for Dr. Kang because he's doing mitral clip. I won't preempt you. I'll ask one question later on.
Okay. So we have to finish this topic and proceed to the next one. The next one will be provided by the Professor Kang from Korea. He is the assistant professor of interventional cardiology at the Anson Medical Center. Today, he wants to give us a talk about the severe functional or non-rheumatic mitral regurgitation in patients with reduced ejection fraction. Professor Kang, please.
Yeah, thank you for your introduction, Dr. Su. I'm Dr. Kang from Anson Medical Center, and I am an interventional cardiologist. So there can be some bias because I'm a mitral clip operator. And my topic is about the decision-making management of severe non-rheumatic mitral regurgitation with half rev. So there can be two situations: one degenerative MR in half rev, two secondary MR related to the reduced ejection fraction. And in the situation, which would be the recommended treatment for the patient, a mitral clip, MV repair or replacement. Because in situation surgery is a long-standing standard of the treatment, and mitral clip is a challenger. So I will talk about on the point of the mitral clip. I have nothing to disclose. And mitral regurgitation, as previously we discussed, it means inappropriate closure of mitral valve and causing backward leaking of the blood. And it's the second most frequent indication for valve surgery. And it can occur from an abnormality of the disease or process that affect any one of the functional component of the apparatus. And there are two types of the mitral regurgitation. First, degenerative MR, primary, and second, functional MR, secondary. And because of the big success of the TAVR for aortic stenosis, many doctors and the companies are anticipating the success of the mitral valve procedure, but it is different in the mitral valve because there are very high variability and instability of the anatomy, and apparatus is very complex, and access is difficult than aortic valve, and there are two different pathologies, primary and secondary MR. And now I will talk about the mitral clip, which is so-called transcatheter edge-to-edge repair, TEER. The TEER is a mimicking procedure of the RFA surgical repair that make a stitch on the A2P2 to reduce the mitral valve regurgitation. And this is concept of TEER with mitral clip. Go into the IVC, RA, and septal puncture into LA, and then clip the regurgitated mitral valve, and then the procedure finishes. This is a very simple concept video that makes you to understand easily about the mitral clip procedure. Septal puncture from RA into LA, and introduce the sheath, and then insert the clip into LA, and then makes a movement to head to the regurgitant mitral valve and go into the LV with the appropriate angle, then catch the leaflet like the RFA repair, and then the procedure is finished. This is the concept of the mitral clip procedure. As you can see, this is transcatheter edge-to-edge repair procedure. It's inherent the limitation of the edge-to-edge repair system. The result can be less appropriate than surgery. As you can see in the right panel, surgery when do the mitral valve repair, the surgeon can do the annuloplasty with the annuloplasty ring and repair the damaged leaflet very consciously, and then result would be perfect. So mitral clip with the inferior result compared with the surgery was tested in the high-risk surgical patient. Then let's check the evidence and guideline recommendations for mitral clip. There are two types of the MR, so guideline and evidence are separated to primary and secondary MR. Let's check the primary MR recommendation first. There was one RCT, Everest 2 RCT, that compared mitral clip versus surgery in randomized trial 2:1, and the age was about 66 and male was 60%. And as you can see in the table, the primary efficacy endpoint, freedom from death or surgery or grade 3 or 4+ MR, was much better. Much better in surgery patient compared with the repair. And mainly the difference was from the resurgery or resurgery for the mitral valve dysfunction. As you can see, the safety, the device group, the mitral clip showed lower safety endpoint because it's a very simple and safe procedure, and clinical success rate was worse than surgery, but acceptable rate. So as you can see in the graph, the freedom from mortality was similar between groups, but freedom from mitral resurgery and reoperation was worse in the mitral clip group. And in 76 high-risk patients subgroup analysis, freedom from mortality was better in high-risk mitral clip group when compared with the concurrent comparator group. So with this result of the worse clinical outcome, but similar safety endpoint, the transcatheter mitral valve repair was recommended in degenerative MR patient with a prohibited surgical risk in 2014. And with the use of the mitral clip for the prohibited or very high surgical risk patient, its use increased. And in 2017, about 3,000 patients in US, the result from the STS registry was reported. The median age was 82, and STS risk score of the mortality for repair was 6% and 9% for replacement. And degenerative MR was 86%, and in-hospital mortality was very low. When considering the high-risk feature of the patient, it was only 2.7%. And death and heart failure rehospitalization rate was acceptable. So in 2020 AH guideline, the treatment of the primary MR recommends that in symptomatic patients with severe MR, the mitral valve intervention recommended irrespective of every systolic function. And in asymptomatic patients with severe primary MR and every systolic dysfunction, mitral valve surgery is recommended by 1B recommendation. And in patients with severe primary MR for surgery, mitral valve repair is recommended in preference of the mitral valve replacement because the outcomes of the repair is well established in long-term history. And when the mitral clip is indicated, it's only indicated in the primary severe MR and high or prohibited surgical risk. And in that situation, the mitral clip is reasonable at 2A indication. And there's another recommendation in the US guideline that in symptomatic or asymptomatic patients with severe primary MR and LV systolic dysfunction, GDM, and in patients whose surgery is not possible, GDMT for systolic dysfunction is reasonable. So this is current guideline. In patients with primary MR and mitral valve surgery is indicated in patients with severe LV systolic dysfunction, but only in patients with high or prohibited surgical risk patient, mitral clip is reasonable. And in patients undergo surgery, mitral valve repair is recommended as first recommendation for degenerative MV disease. And there are major guideline changes from the prohibited surgical risk to a high or prohibited surgical risk, and 2B recommendation, 2A recommendation for mitral clip. But you must remember there are unchanged indication for mitral clip for primary MR. There is only severely symptomatic patient and favorable mitral valve anatomy and life expectancy more than 1 year and high or prohibited surgical risk. This is the anatomic feasibility of mitral clip. And in patients with the unsuitable mitral valve, then mitral clip is not a good treatment choice. So there will be a scenario 1 for primary MR in patients with half rep. Surgery is treatment of choice, and MV repair is usually recommended. In high surgical risk patients without need of other cardiac surgery like KBG or other valve procedure, mitral clip is reasonable. So heart team discussion is essential. This is our case, 83-year-old male patient primary MR as a history of persistent AFib, hypertension, angina, and mildly decreased LV systolic function and severe eccentric MR. And because the patient is very old, 83-year-old, and there is diffuse atherosclerosis and heart team discussion considering old age, ST score of mortality high and a high risk of stroke. So we decided to perform the mitral clip procedure. And with a simple procedure of the 2 hours with just femoral vein puncture, the patient was treated and now doing well over 1 year now. And now let's talk about the secondary MR. This is the main topic for mitral clip for half rev. So there was no recommendation in 2017 about the secondary MR valve guideline for transcatheter MV repair. And after then, there was 2 randomized trials in 2018. One is the mitral trial in France that randomized 300 patients to mitral clip versus medical treatment for the functional MR patient. And the result shows that no difference between mitral clip versus medical treatment. Everyone was disappointed at this moment. And another trial from US with a large size, 600 patients, a COAP trial was published in 2018. And it also randomized mitral clip versus OMT by one. And the key inclusion criteria was more strict than mitral FR trial. Ejection fraction 20 to 50%, LV and systolic diameter equal or less than 70 millimeter, and severe or moderate to severe MR by US ASC criteria more strict, and their functional class 2 to 4 despite a stable maximally tolerated GDMT, including CRT. Over 20% patients receive CRT. And the patient with the established pulmonary hypertension patient was excluded. And this is the primary effectiveness endpoint of the overall hospitalization for heart failure for 24 months, and much better in mitral clip compared with the medical treatment. And all-cause mortality was showed about 40% reduction in mitral clip patient. And number needed to treat to prevent 1 death was just 5, a very excellent result to prevent death. And in the extended follow-up in 3 years, the difference was maintained in mitral clip. And the safety endpoint, the freedom from adverse event was very low, very high in mitral clip patient. And all device-related complication rate was very low. So MR severity, 3 or 4+ in orange or red color is well decreased after mitral clip and well maintained over 3 years. So this is comparison between COAP and mitral FL trial that did not and did show the benefit of the mitral clip in functional MR patients. What would be the difference? And some very thorough analysis showed that mitral clip patient did not show benefit in patients with greater LV enlargement and less severe MR in mitral FR patients. That means if the patient has the long-standing MR, so LV enlargement and LV systolic failure progressed, then at that moment, the role of mitral clip is not so big. And in COAP trial, the patient LV volume was relatively small, and the degree of the regurgitation was very high. In this kind of the disproportionately very severe MR patient was benefited with the mitral clip procedure. So this is another conceptual framework from the previous old trials that showed mitral valve surgery or mitral clip or CRT showed beneficial. The patient indication was in the patient with the smaller LV volume with higher degree of the regurgitation. In trials that did not show benefit from the surgery CRT mitral clip was targeted the patient with the relatively larger LV volume and smaller degree of the mitral regurgitation. So targeting this kind of the population would be very important for successful mitral clip procedure for functional MR patients with reduced LV ejection fraction. So in 2020, US guideline was updated with a new recommendation of mitral clip for a COAM-like patient. That this is the sentence of the recommendation. In patients with a chronic severely secondary MR related to the LV systolic dysfunction, if the patient is persistently symptomatic despite on the optimal medical therapy, a mitral clip would be reasonable for appropriate anatomy and LV ejection fraction between 20 and 50, and LV and the systolic diameter equal or less than 70 millimeter, and pulmonary arterial systolic pressure equal or less than 70 millimeter mercury as 2A recommendation. And how about the surgery for functional MR? There can be some techniques, a downsized annuloplasty repair or valve replacement with caudal sparing. And surgery, actually surgery has not been shown to improve long-term survival for functional MR patients because there was no large-sized trial yet. But the advantage of the surgery is that it can be done with the other procedures like CABG or LA appendage amputation in AP patient or other valve surgery. There was some RCTs for functional MR patient. One is CTSN RCT1 that compared MV repair versus replacement in patients with severe ischemic MR. And 75% patients received concomitant CABG and 12% MAGE, and mean CPV time was 144 minutes. They showed MV repair and replacement showed similar death rate at 24 months, and major adverse cardiac event was similar between groups. However, the degree of the moderate to severe remnant MR and heart failure and severe admission rate was higher in repair group compared with the replacement. Second RCT is CABG versus CABG plus MV repair for moderate ischemic MR patient. 300 patients was randomized, and moderate to severe residual MR was remained more in the CABG group. But the death rate and major adverse cardiac or cerebrovascular event was similar between mitral valve repair plus CABG and CABG alone group. So mitral valve repair, in addition to CABG, could not prove its role in ischemic MR. So there are pulse of data showing benefit of surgery over medical therapy in functional MR, and there is no robust head-to-head comparison of surgery versus clip yet. And there are many ongoing mitral clip or other TMVR trials, but they are focused largely on functional MR. So my concern is that surgery for functional MR is rapidly being superseded by catheter therapy like mitral clip. So its true effectiveness can likely not to be known. So this is the current recommendation for secondary MR with half rev. In patients with the COAP trial criteria and 2A recommendation, mitral clip is recommended. And if the patient needs CABG, and mitral valve surgery is reasonable as 2A recommendation. And in patients with atrial annular dilation with the AFib or other lesion, then mitral valve surgery may be considered. And the patient with the LV systolic dysfunction and secondary MR and still persistent to severely symptomatic, surgery may be considered, but this is 2B recommendation. And in patients with the coronary artery disease and chronic severely secondary MR and caudal sparing mitral valve replacement may be reasonable to choose over downsized annuloplasty repair on the basis of the CTSN-1 trial. So this is the current flow chart of the decision making. GDMT first. This is the class 1 recommendation. And still symptomatic patient that ejection fraction less than 50 and anatomy favorable and meet this criteria, then mitral clip can be done. And in other case, when need CABG, surgery is recommended. And other case, surgery can be considered as 2B indication. And or for this kind of functional patient, standard GDM and cardiology expert in the management of the heart failure is #1 recommendation. So this is an updated recommendation for secondary MR. And we have another strong weapon for heart failure patient on mitral clip. Heart failure specialist provides optimal GDMT before and after mitral clip is the most important. So there can be scenario 2, secondary MR in patient with half rep. If the patient meets core criteria, mitral clip is recommended as 2A. In patient who need CABG, surgery is reasonable as 2A. And in patient, if the patient undergoes surgery, caudal sparing mitral valve replacement may be reasonable to choose over downsized annuloplasty repair. And most of our guideline-directed medical therapy should be maximized. So this is my last case. The 73-year-old female patient with DCM 29% ejection fraction, long-standing MR, and severe functional MR intractable to dyspnea despite of the maximal medical treatment. Severe cardiomegaly and dilated LV. And TEE also showed eccentric functional MR and with moderate pulmonary hypertension. So this kind of patient, we must check the anatomy, and the anatomy was feasible, and the patient was here of disproportionately very severe MR compared with the size of the LV. And mitral clip procedure was done in 2 hours, and the result was great. And the mitral clip was done in 2 hours, and minimally invasive, and discharged in 3 days. And 2 months after mitral clip, the patient symptom improved and cardiomegaly improved, and we could maximize the medication because the blood pressure increased. And TTE after 2 months showed decreased LV cavity size with improved LV systolic function and improved RV contractility, and pulmonary hypertension disappeared. This is comparison before and after procedure. And then how to maximize mitral clip success in FMR. Maximal GDMT is important, and selecting the good candidate is very important. And heart team is very important. So this is summary. 2020 updated mitral clip is stable anatomy, and primary MR, high or prohibited surgical risk. Secondary MR, persistent after GDMT and meet this criteria. And also in Asian Pacific Society of Cardiology made a consensus recommendation for use of the mitral clip for MR. And it was published this year, and maybe you can make a reference to treat patient. This is summary. Mitral clip is a reasonable alternative for significant MR patients with high surgical risk. For primary MR with half rep, mitral valve repair surgery is preferred. Mitral clip is recommended in high or prohibited surgical risk patients. For secondary MR with half rep, mitral clip is recommended for persistent symptomatic MR patients even after GADMT. And appropriate decision making by heart team is important. Thank you for your attention.
Many thanks, Professor Ken, about your excellent talk in management of functional MR in patients with reduced ejection fraction. Any questions from the other speaker?
Dr. Kang, in real world, how many clips do you normally put inside the patient when you do your mitral clip procedure?
In our center, the average value of the clip was 1.7. And that means many patients receive 1 or 2. And usually in functional MR, we needed 2 because the valve area is larger and the regurgitant area is larger. And in cases with the degenerative MR, 1 is more prevalent. And with the G4 system that has the larger size of the clip, and the number of the clip is decreasing.
Is this a just to ask because this is a very prohibitive device in our place. How does the patient pay for the clips? Does the company give one clip, and if you need two, they don't charge the second clip? How does it work in Korea?
Yeah, that's a problem because we just started the mitral clip last year, and just 1.5 years passed, and it is not covered by the health insurance system yet. So 100% paid by the patient, and that's the largest hurdle for the mitral clip procedure.
Okay, that's the same.
How much it costs?
Very expensive.
Very expensive.
About 30,000.
30,000, yeah, US.
US dollar. Very
Here,
expensive. So,
it's about we spent about 4 million pesos divided by 55. That's the exchange rate, US to Philippine peso. So that expensive. That's why it's
actually we talk much about the guidelines and the evidences, but number one decision priority is the price.
Right. Being able to pay. Yeah, I think.
And when you decide that second device is being put in or required during procedure?
So if the first mitral clip could not catch all the regurgitant areas, and we plan to implant second clip. And usually we plan before the procedure with the TE images, 1 or 2 clips, and the consideration to add 1 or not is that the mitral valve area, remnant mitral valve area of the first clip, or pressure gradient. If the pressure gradient rises over 5 or mitral valve area decreases, then the second clip would be avoided.
If you have like moderate mitral stenosis or mild mitral stenosis, then you have to stop.
Yeah, mild MSC would be okay, but moderate severe is not. It's bad.
Because of the time limitation, so we have to proceed to the next 2 topics. The next 2 topics will be chaired by the Professor Gong. Professor Gong, please.
Yeah, thank you. Next topic is told by the Dr. Leonardo Estacio from the Philippine Heart Center. He is the invasive cardiologist, and his topic is the decision making in management of the new onset mitral regurgitation, complicated in acute STEMI or non-STEMI, PCI, CABG, mitral repair, or hybrid. Very difficult topic.
Yes,
in very
very
difficult
hard
situation.
I hope I can give justice. Yeah, okay. I'll share my slides. Very well. I can't. I'll just play my slides. Seems that. Sorry, but I'm having problems. I'll stop share first, and then I'll share again. Okay. Give me a few seconds. I'll just call somebody to help me here.
Okay, then shall we? Oh no, yes. Then shall we exchange the? Is it? Oh, he's coming back. Yeah. Okay.
Slide. Hindi ko ma. Play lang. Share slides. Okay. Okay. Tanggalin. Okay, sorry for that. My talk for today is, thank you again for inviting me, but my talk is really difficult because I cannot really find any guidelines or any journal to make the discussion. But I'll try my best with some of the uh, just some of the small articles that I've seen. Decision making in acute myocardial infarction, in ACS and revascularization. First is mitral regurgitation, as we have known, has been primary or secondary. For primary, you have problems with your mitral valve apparatus, and for secondary, it's more the dilatation of your mitral valve annulus. And disease progression and natural history, you have heard that severe MR untreated has fairly poor prognosis, irrespective of the etiology. You will have worse quality of life, heart failure symptoms, and atrial fibrillation. So with mitral clip here and GDMT, hopefully you can alleviate some of these factors. Um, Therapy for severe acute onset mitral regurgitation is always surgery. But I will discuss some instances wherein post PCI, post TEMI, and post ACS, you will have some mild or moderate mitral regurgitation, and what you should do with this. But for severe mitral regurgitation occurring during ACS and this patient goes into shock, definitely the treatment would be revascularization with mitral valve surgery. So this is just what they call atrial functional MR, wherein you have an isolated atrial fibrillation, the presence of normal leaflet. Okay, secondary MR, you should treat them with heart failure regimen, cardiac resynchronization therapy. If you have coronary artery disease, treat the CAD. Class 2B surgery for grade 3 or 4 secondary MR despite OMT. And in general, neither mitral valve replacement nor repair has been shown to improve survival in treatment of severe functional MR. So for ischemic myocardial regurgitation, is a common occurrence following myocardial infarction, and its presence is associated with poor outcome. If you have a ischemic myocardial infarction and the MR is mild, then treat the CAD and observe. They have found out that normally you have to follow up these patients who have coronary artery disease with trivial or mild MR. Treat the CAD first with either PCI and cabbage, and monitor this patient's MR, because in the long run they have a propensity to progress because of, they've said, LV remodeling or progression of your ischemia. For coronary artery disease with severe MR and a dilated annulus, as I've stated, you can treat it with cabbage and repair or replacement of the mitral valve. The problem is when it comes to moderate MR. So this is a gray zone wherein there is a lot of debate whether to touch or not to touch moderate MR. So ischemic myocardial infarction following acute myocardial infarction. IMR, it has been shown that if you develop AMI or acute myocardial infarction with the presence of MR, whether mild, moderate, maybe severe, the mechanical reperfusion, either PCI or CAVG of the infarct-related artery is superior to fibrinolysis or medical management alone. This is because when you do your PCI or even revascularization patient with AMI, you recruit most of the hibernating myocardium. And if you have an MR secondary to an ACS, recruiting the myocardium prevents or increases the contraction of your myocardium. It shortens out or improves the papillary muscle function, and sometimes it improves your MR. The only problem with AMI is that when AMI is accompanied with MR and on 2D echo, you have papillary muscle rupture. And usually in patients with papillary muscle rupture secondary to acute myocardial infarction, these are patients that goes into cardiogenic shock. So if this happens, then I think the primary treatment would be putting in your support devices, lowering down your afterload with medication, and calling in your friendly neighborhood surgeon to do uh, your cabbage and mitral valve repair. As we have said, in this era of PCI, early revascularization in patients with AMI is a key improving survival. MR following AMI, MR is an independent predictor of long-term cardiovascular mortality. Risk factors for having MR or the progression of MR would be advanced age, prior MR, infarct extension, and recurrent ischemia. Remember that if you are not able to open the infarct-related artery, there's still some ischemia ongoing, and in the future, a moderate or a mild or moderate MR can become severe secondary to left ventricular remodeling. And this is where your problem or heart failure would start. During acute myocardial infarction, there is an early phase MR wherein there is a transient ischemic MR, which is common secondary to recurrent ischemia. So if you treat the infarct-related artery, normally the ischemic MR disappears and there is no hemodynamic compromise. But when several chorda tendinae or papillary muscle ruptures, then this is where your patients will develop acute cardiogenic shock. And this is where you have to call your surgeons to do cabbage for the coronary artery as well as mitral valve repair. And usually in patients who does not develop any hemodynamic compromise um, and has mild or moderate MR, usually they just treat the culprit artery or the infarct-related artery, and they just monitor these patients in the long run, because sometimes these patients undergo remodeling and the MR may progress from moderate to severe. So mild functional ischemic MR following AMI, in one study, it's just 94 patients. Group 1 had mild MR. These are diabetic patients, elderly, smoker, hypertensive. They have more STEMI than NSTEMI. And group 2 has no MR. They found out if you only have mild MR, there's no difference in in-hospital mortality and cardiovascular outcomes. And no revascularization for the mitral valve is needed. IMR in ACS STEMI and STEMI, there's one prospective single center study, and they have found out even after primary PCI, they have found that at discharge, there was ischemic MR was found in 42%. And LV remodeling in 6 months when they follow up this patient is 25%. And predictor of left ventricular remodeling in 6 months was ischemic MR severity. So if you have severe MR and a low EF, then these patients normally go into heart failure. So the highest incidence of ischemic MR in patients with is seen in inferior wall rather than the anterior wall MI. This is because of the position of the papillary muscles. So in this study, they had an inferior, they collected patients who developed AMI with inferior and anterior wall, less global remodeling and dysfunction, but greater ischemic MR incidence in patients with inferior wall MI. This is because of the effect of the right coronary in the position of your papillary muscle. The ejection fraction was preserved in inferior wall compared to the anterior wall. The MR incidence jet was about 38% if you have an inferior wall and 10% if you just have an anterior wall. This is because of the posterior papillary muscle tethering distance greater in inferior wall. So the greater geometric changes in the mitral valve apparatus with greater displacement of the papillary muscle caused by localized inferior basal remodeling. So it's still important that if you have an inferior wall MI is to get this patient early during the golden period and reperfuse the culprit artery just to prevent ischemic myocardial regurgitation. Okay, the course of ischemic MR in AMI after primary PCI. Still, primary PCI can provide dynamic improvement of LV function, which should dramatically affect the magnitude of IMR, because this improves the myocardial function, prevents dilatation of your LV and tethering of your papillary muscles. So it brings your mitral valve apparatus together, cooptates, and reduces the MR. The acute effects of primary PCI on IMR and its relation to degrees of LV parameters, meaning the lesser the higher the left ventricular function and the smaller the LV during the acute PCI, the lesser would be your ischemic myocardial infarction regurgitation. However, if during primary PCI you already have a very bad LV, sometimes this patient during the chronic phase can remodel and cause severity of your MR. Okay. Predictive factors for phasic changes in acute IMR. You should be able to get this patient early. The shortest onset of to reperfusion time or door to wiring time should be less than 90 minutes if feasible. And then when you go to the cath lab, your TIMI flow should be, they say it's more than TIMI 1, but Dr. Kang would disagree with us. You have to get a TIMI 3 flow to improve recruitment of your ischemic myocardium, and this will improve your IMR. But higher age, lower EF at acute phase, and higher peak CKNB were independent predictors of persistent more than mild MR at 6 to 8 months. So if you have a low EF, heart failure symptoms, in higher CKMB, these are patients with ischemic MR post-PCI that you have to monitor because they remodel and the MR becomes more severe after the acute phase. Okay. The course of ischemic MR in AMI, IMR was seen in 36% at patients presenting at the ER. Majority would be mild in the patient in the paper of Nishino. Moderate would be 24 and 10% would just be severe. And they have found out that when they do a PCI in acute myocardial infarction, usually the mild and moderate MRs usually downgrades to either disappearing or the moderate would be mild. So it's still a good practice to open up the culprit artery. But there are some patients whose MR still persists to become severe. And these are problematic patients because they have 30-day worse outcome. So I think these are patients after PCI of the culprit artery, which has severe MR, has to be placed on a heart team approach as what to do with your mitral valve. And if the question is post-PCI, how do I stop my anticoagulation treatment? But now there are stents available that you can stop it within a month and go for other surgery. So long-term prognostic value for MR, MR grade was inversely related to EF and directly related to the BNP level. So if you get a patient with ACS, low EF, high BNP, then these are patients who have very poor long-term outcome. Older patients, history of MI, congestive heart failure, and previous angina are also prognosticators for long-term poor outcome. So treatment strategies for acute coronary syndrome with severe regurgitation and their effects on short and long-term prognosis. I think mitral regurgitation of even mild severity affects the prognosis of patients with acute coronary syndrome. So if you have severe MR and ACS, CABG plus MVR in the acute phase is the treatment and not PCI alone. But if you have a moderate or mild MR during ACS, I think opening up the culprit artery or either opening up the culprit and non-culprit artery will improve your ischemic mitral regurgitation. So the effect of revascularization strategy on the severity of ischemic moderate MR is still in question. So it's either you do PCI alone or CABG. So the idea is LV dysfunction resulting from hibernating but recoverable myocardium has been the option of treatment when revascularization is improved. So you have to recruit as many as recoverable myocardium as possible when you treat patients with acute ischemic MR. And with this, you improve myocardial perfusion, and you usually reverse the dilatation or remodeling of this patient. So IMR and CABG and IMR post-CABG. The impact of moderate ischemic MR is really a debate. Ischemic MR before CABG or after isolated CABG increases the incidence of cardiac-related deaths and all deaths in patients, especially with low EF. Ischemic MR affects survival in 5 years in patients with very low ejection fraction. So there are two groups and there are two debates, two schools of thought. The best clinical data available today supports that isolated CABG with moderate MR is the treatment of choice rather than CABG and mitral valve replacement. I see Dr. Shu smiling. Maybe he can react later on. But in some papers, they've said that if you do isolated CABG with moderate MR as compared to CABG and repair the mitral valve, the long-term outcome still no difference. So they would say that isolated CABG is still the treatment and just monitor this patient later on for the progression of MR. In the CABG group, they say that you do CABG and mitral valve replacement because it will depend on the myocardium that you can recruit. If there are some scarred area, then you know that doing CABG alone without CABG alone with severe scarring will not improve the LV geometry. So they say that you have to repair your mitral valve. But in the other group, for isolated CABG, they would just say that if you have a big area of myocardium at risk and you can recruit them, then doing CABG alone will decrease the ischemic burden on the papillary muscles and on the LV and just decreasing your MR. So I think for ischemic MR, moderate ischemic MR, I think you still have to go for a heart team approach, whether you want to do isolated CABG or CABG plus mitral valve replacement. So studies demonstrated that improvement in MR in patients with moderate mitral regurgitation who underwent isolated CABG was limited to patients with viable myocardium and the absence of desynchrony between papillary muscle. So if you don't have lots of viable myocardium, you undergo CABG and you have a mitral valve moderate MR, they suggest you might as well change the mitral valve because this will not improve just with isolated CABG. And persistence of the MR may even progress and increase your mortality in the future. Recent RCTs, moderate and severe ischemic MR and mitral valve repair or replacement with chordal sparing failed to achieve long-term favorable effects on clinical outcome. But subgroup analysis demonstrate favorable reverse remodeling. So I think these are patients who still would need more studies in to see whether really touching the mitral valve with valve chordal sparing would be beneficial rather than just doing CABG. For moderate ischemic MR, decision is affected by your echo parameters, your ejection fraction, the risk, whether CABG plus MBR will pose a greater risk, and the synchrony and fibrosis in your myocardium. Mitral valve replacement or repair after previous CABG. Sometimes if they have a residual MR after CABG and the patient is hemodynamic, if it's mild or moderate, they do not touch it and just put them on medical treatment. There's one case study that I want to share. This is a clip, they call it an eclipse MR, transient severe MR. An 83 female, normal EF, no valvular heart disease. Every time she'd go into chest pain, you do the echo, there's severe MR. And then when the chest pain disappears, the MR will disappear. And they did several angiograms in this patient. The patient would have normal coronaries. and they treated this patient with just mononitrates and calcium antagonists, which improves the MR. But unfortunately, this patient died. And when they did the autopsy, they found a subendocardial infarction with hemorrhage in the anteroseptal wall. So this is a very rare case. Another case report that I've come across is that it's a 57-year-old male, STEMI, apparently at the ER had an anterolateral wall. They did in an angiogram, the culprit was a dominant circumflex. They performed the angioplasty very well. After 2 days, the patient developed chest pain and a moderate MR. So they did a echo and found out that there was tethering of the mitral valve. They did a look at the coronary angiogram. They found out that there was stent thrombosis. So they just opened up the coronaries again, make sure they plastered the stent very well, and the MR disappeared. Transient MR after mitral valve replacement is associated with clinical outcome. There's only case series. Post-operatively, they detected SAM or MR post-op were successfully managed medically with good short and long-term outcome. So reintervention or bringing this patient back to the OR is associated with poor outcome. So after repair, if you have residual MR, they just go for GDMT. The role of mitral clip for ischemic MR is still limited. There are some institutions that do mitral clip for acute MR in patients with ACS, but I think Dr. Kang has stated it's still not in the guidelines for this type of patients. So in conclusion, ischemic MR significantly impacts the outcome and prognosis of CAD cases. Revascularization is still superior to OMT in CAD with ischemic MR. Decision for CABG and PCI would vary. It depends on so many factors. For severe MR patients with ACS, I would suggest that you go for surgery. But for patients with moderate, mild MR, hemodynamically stable, acute coronary syndrome, you just open the culprit vessel. IMR can improve. It may not change or even progress after revascularization. So in patients whom you perform PCI or even CABG with residual MR, these are patients you have to monitor very closely for the progression of your myocardial infarction or myocardial regurgitation, and put this patient on adequate heart failure regimen. Decision is hardest for moderate IMR. Two proponents, Revasc alone or Revasc with replacement. Most evidence would show superiority of Revasc alone and observe IMR, but I think there is no big data to make this a sweeping statement. So I think it would still be best to discuss it with the heart team once you have this situation. Most evidence that we have are retrospective studies, a lot of small studies with diverse revascularization. This is still considered a gap in knowledge. We need stronger studies to be able to provide us and guide us in our treatment. And with this, I thank you very much.
Great lecture, Dr. Estacio. Great lecture, all covering the whole aspect of the ischemic mitral regurgitation with a beautiful slide. And in my experience, because I'm an interventional cardiologist, acute ischemic MR accompanied with a STEMI is a disaster. Usually, we after the in shock patient, after very busy PCI, then we find that the patient has acute severe MR with the caudal rupture or papillary muscle rupture. Then we send the patient to the surgical room.
Yes.
And I think that in that situation, the patient is in shock and just received PCI and during antiplatelet high degree of the high dose of the heparin. And in those situations, mitral clip would work, what is your personal opinion? There's no data yet.
Yeah, there's
Only
no
case
data.
studies. Yeah.
Well, our experience here is really
Yeah.
very, very limited. I think we just had 4 clips because the patient cannot afford. But I think this is one area where mitral clip can be studied. But the problem is if you have chordal rupture, do you think? I don't think mitral clip will be able to help us. The surgeons would definitely just do valve replacement outright. And for me, if the patient is in shock and we've done everything in the cath lab, I think we have to share our problems with the surgeon, and especially in patients with severe MR. But if we are doing our culprit PCI develops MR in, say, in the ICU, hemodynamically stable, maybe at moderate MR, maybe we can just observe this patient and treat them and follow them up closely in the future. And if the MR progresses, then I think you would have more relaxed time doing your mitral clip. But I don't like to do mitral clip in a very stressful situation. Maybe just give it to the surgeons.
Great opinion. Okay.
Yeah.
Thank you, Dr. Estacio, for your excellent talk. I just want to share my experience for acute MR patient using MetaClip. We have done, I think, few cases of MetaClip in this situation. I think it's doable, but only concern is left atrial dimension, because for the MetaClip therapy, you know that the transeptal point would be 4 or 4.5 centimeter, but in this situation, the left atrial dimension is normal. You cannot get the 4 or 4.5 as a recommend. Usually you get a 3.5 or at most 4 centimeter. You need to do some gaining height procedure to get some height, and you would get a good result from this. We have done, I think, 3 or 4 cases of acute MR using MetaClip when I was a fellow at Cedars-Sinai and in Thailand also. Sometimes you need some support like impeller or IABP or ECMO during the procedure. And after the procedure, most of the patient recovery very, very well and so quick. The ECMO or impeller can be removed in next 1 or 2 days. That's my comment and my experience for share. Thank you.
I have a comment. I know we are running very already short of time, but I really congratulate Ronaldo for his nice presentation. But basically, it's not black and white. Say, for example, we are looking at a patient 3 a.m. in the night, and we do primary inferior MI. Somebody did an echo and say moderate MR. Even it's not clearly what's going on. Definitely, that patient has been proceed for primary angioplasty. In the morning, it's clear that there is a cardiac rupture. Now, surgeon is very reluctant to take that patient. In guidelines, it's very easy to put things black and white, but practically, clinically, it's very difficult scenario. But what is our experience by putting a stent opening artery? Definitely, there is a reduction in mitral regurgitation unless there is no structural issue. But if there is a cardiac rupture or some other problems, then it's very difficult to manage it only by opening the vessel.
Dr. Su, you have some opinion as a surgeon.
Yeah. You know that in patients with acute myocardial infarction, there are several factors can induce the severe mitral regurgitation. In the extreme example is the papillary muscle rupture. For patients with papillary muscle with acute myocardial, but after myocardial infarction, there is no way to do the mitral clip for that, because during the operation you can see the papillary muscle disruption and invert to the left atrium. There's no place for the mitral clip to repair that. This is the first question. And for the ischemic MR in patients with coronary artery disease, my opinion, my personal treatment strategy is that if the patient have good Purkinje vessel and abundance of viable myocardium, even patient has severe MR, you can do CABG alone, because the addition of mitral valve surgery to isolated CABG, the operating mortality will increase. So if the patient have very good Purkinje vessel and the viable myocardium, usually I will do isolated CABG alone, because the most of the patient will have the improved mitral regurgitation after surgery. If the patient have chronic history of heart failure and also the scar myocardium, then you have to consider the combination of CABG and the mitral valve repair. For the mitral valve intervention in ischemia MR, personally, I prefer the mitral repair. You know, although in several previous publications showed that the replacement is better than the repair. However, you know, the mitral repair is technique dependent. You have to learn how to repair the ischemic MR, not to replace the valve with not durable the valve, you know. So personally, I always do the mitral repair for the functional MR. Yeah.
I think Dr. Shu is right. If you are very good in doing the repair, I think you should repair a MR. But having said that, if our system does not provide patients going back, so we tell our surgeons, if you cannot do a repair properly, might as well change the valve. So I think I agree with Dr. Shu. The mitral valve repair is technique dependent and operator dependent.
Right.
Great discussion. Yeah, great discussion for the very difficult and hard issue. But because of the time limit, we will proceed to the last lecture from the Dr. Krisida Mimuk from Thailand. He is a clinical instructor of Division of Cardiology in Lamthap Body Hospital and Mahidol University, Bangkok, Thailand. He will talk on another very difficult but important issue of the decision-making and measurement of senior MR in hypertrophic obstructive cardiomyopathy. Dr. Mimuk, please.
Thank you, Dr. Kang, for your kind introduction, and good afternoon, ladies and gentlemen. My today talk is about management of mitral regurgitation in hypertrophic cardiomyopathy patient. It is my disclosure. Let's start with the case presentation. This is a 65-year-old female with known hypertrophic cardiomyopathy with my MR.
I'm so sorry, but I cannot see your slides.
Oh yeah. Oh, sorry. Yeah, let me stop sharing and I could share it again. Can you? It's moving.
Yeah.
It's moving. Okay. Yeah. Okay. Let's start again. Yeah, let's start with the case presentation. This is a 65-year-old female with a known hypertrophic cardiomyopathy with a mild MR. She presented to another hospital with a sudden dyspnea while having run for a week. On the examination, the holocytic murmur can be heard at the apex. On the chest X-ray, you can see the cardiomegaly with pulmonary congestion. The left finding show elevation of high central troponin T and also NT-proBNP level. I was consulted from my heart failure colleague for being considered transcatheter treatment for this patient. The ECG show normal sinus rhythm with LV hypertrophy with strain pattern. The echocardiogram performed at my hospital. You can see the concentric hypertrophy with a significant MR and leader moderate to severe right here. And the LVOT gradient was measured, showing that about 52 of the gradient across the LVOT. The eject, obstruct, and leak concept has been widely accepted at the cause of mitral regurgitation in hypertrophic cardiomyopathy patient. But other factors like a papillary muscle abnormality or intrinsic mitral valve abnormality can be can be cause of MR in HCM patient, especially in for the caudal rupture. It can be found in 1 to 5%, and it's often lead the patient to severe MR requiring surgical or intervention therapy. The echocardiogram is useful for evaluation of the LVOT gradient as well as SAM and degree of mitral regurgitation, and it can be detect the intrinsic mitral valve abnormality and also the mitral regurgitation direction. If the information from the transthoracic echo is not clear, the esophageal echo is an optional. For our patient, because we cannot identify the exact pathology of the MR in the patient, we decide to perform the TEE. You can see the SAM right here, systolic anterior motion causing the LVOT obstruction and also the mitral regurgitation. On the right panel, you can see the MR has two jets. One is a posteriorly directed jet. If you see the posteriorly directed jet MR in HCM patient, it's likely to be a SAM-related MR. But if you see central jet or even anteriorly directed jet like this patient, the intrinsic mitral valve abnormality should be sought, like a prolapse or caudal rupture. In this patient, you can see the MR has two ways. On the biplane system, you can see the caudal rupture of the P3 segment. So in this patient, the MR came from two mechanisms. One is a anterior septal jet MR from the failed P3, and another mechanism is a posteriorly directed jet MR from caudal and leaflet SAM, because this patient has mixed mechanism of the MR. Coronary angiogram and left heart catheterization is also useful in evaluation of the coronary anatomy, including septal branches for echoseptal ablation candidates, and the degree of LVOT obstruction can be measured by this invasive method. Back to our case, we perform the coronary angiogram. You can see the CAG show the non-obstructive disease, and you can see multiple septal branches, 1, 2, 3, 4, 5, and also the septal bridging of all proximal septal 1, 2, 3, 4, 5. We perform the LV gram. You can see the LV kissing during the systole, and also MR was severe, and you may appreciate the SAM right here. We calculate the resting LVOT gradient that's what 65 millimeter mercury, and on the pullback you can see the gradient occur at the level below the LVOT. What should we do for this patient? Send the patient for surgery to do a myectomy alone, or do the myectomy and mitral valve surgery, or send the patient to do the pacemaker implantation or echoseptal ablation, or as we talk a lot today is transcatheter edge-to-edge repair for the patient. The septal reduction therapy is the gold standard for treatment of the hypertrophic cardiomyopathy with MR, because it can reduce the LVOT gradient and improve the outcome, short and long-term outcomes compared to non-intervention obstructive individual. And also the mitral valve surgery can be concomitantly performed in HOCM patient by shortened elongated anterior leaflet, or do the papillary muscle release or relocation, or even do the mitral valve repair or replacement for treatment of the leaflet pathology. The extended septal myectomy performed transaortically. It can be solely done without mitral valve surgery if absent of intrinsic mitral valve disease, and extended septal myectomy is properly performed. The surgeon can exit the muscle from the septum up to the apex. If is performed properly, the mitral valve should not be touched. This is the outcome study of myectomy. It's long-term outcome for 10 years from the Mayo Clinic. You can appreciate the back thick line. Right here is a myectomy patient. In the myectomy patient, there's a comparable outcome to the non-obstructive patient. But if you look at the non-operated obstructive patient, they has the worst outcome compared to two subgroups. The concomitant septal myectomy and mitral valve surgery should be considered in the HOCM patient with the intrinsic mitral valve disease, especially CVMR from mitral valve collapse or even a caudal rupture like a outpatient. For the recommendation, mitral valve repair is recommended over valve replacement if it's possibly performed. Another option is the alcohol septal ablation. This is a transcatheter less invasive selective alcohol-induced myocardial infarction at the septal branch, lead to decreasing of the septal hypertrophy and LVOT gradient. This is the outcome from the Mayo Clinic again. For in 200 patients, compare the myectomy and alcohol septal ablation. At the 4-year follow-up, you can see in the all patient, the myectomy has a comparable to the alcohol septal ablation in terms of survival-free of death and severe symptom. But if you look at the patient age less than 65, you can see the myectomy has a better outcome compared to the alcohol septal ablation alone. This is our another case example for alcohol septal ablation. This is a 69 years old female with underlying of systemic sclerosis with interstitial lung disease. She was diagnosed with HOCM for a few years with a resting LVOT gradient of 75 and moderate MR. 1 month before admission, she complained of the progressive short of breath with the NYHA progress from 1 to class 3 with the ONT at heart rate with the 50 on the optimal dose of beta blocker. On the exam, you can hear holocytic murmur at the apex and also at the left lower parasternal border. The echocardiogram, you can appreciate the SAM right here and acceleration flow at the LVOT and also moderate MR. The LVOT gradient was 23 of the peak pressure. Because her age and comorbidity, including the interstitial lung disease, we decided to perform alcohol septal ablation. After we select first septal branch, we inject the contrast echo right here. You can see the brightness of the echo contrast at the septum at the area of interest that we use to ablate. After that, absolute alcohol 1.2 milliliters was injected using the over the wire balloon. This is the outcome after alcohol septal ablation. You can appreciate the gradient now is gone near to 0. This is a 30-minute procedure. You can appreciate the reduction of the LVOT gradient from almost 100 to the 0 is dramatically reduced in this patient. We perform echo at 6 months because the guideline recommend to perform echo at 3 to 6 months after the procedure to evaluate the gradient. Now its gradient is gone. The peak pressure gradient is about 15. And if we compare the echo images to the before the procedure, after the procedure, you can appreciate the thinning of septal myocardium and also the hypokinesis of the septal wall that lead to decreasing in the LVOT obstruction. Another option is dual chamber pacing. The dual chamber pacing can reduce the gradient compared to the baseline and placebo. They open mode AAI after push dual chamber. DDD pressing can reduce the gradient by about 30 millimeter mercury, but it failed to show benefit in terms of functional class improvement by using a treadmill exercise test. So now it's not in the US guideline recommendation anymore for dual chamber pacing. There are some limitations of the septal reduction therapy. As you know that the surgical myectomy or alcohol septal ablation has been shown to be effective for reduction of the LVOT gradient or the improvement of the MR. But they are increasing the risk of cardiac arrhythmia, ventricular septal defect, and the heart block requiring pacemaker implantation, especially in the alcohol septal ablation. And they cannot be performed in the patient with elevated surgical risk or the septal endotomy is not feasible to do the alcohol septal ablation. Another potential therapy for this is to use a TAN catheter edge-to-edge repair using the mitral clip, because the mitral clip can treat the SAM and the MR and LVOT obstruction with the one device. We have one case of our SCM patient. This is a 78 years old female. She was diagnosed with SCM for a while, and she has AICD implantation and optimal medical therapy. She was in NYSA class 2, and the echo show MR was not severe. But a month ago, she presented to the emergency department with a Western heart failure, and the echo show a severe MR. And now is the MR caused by the SAM and new fail of the P2 and P3 segment. Because her is very, very old and her functional status is very poor, surgical candidate, we decide to do the mitral clip. This is a less than a 15 minutes procedure. You can see the outcome after one clip. Now its MI is gone, and SAM is gone also. If you compare the chest X-ray, this is the pre-procedure. You can see the cardiomegaly and also pulmonary congestion and right pleural effusion. The right pleural effusion is persist for a year because heart failure cannot be controlled. This is the day one after the procedure. We put one mitral clip here, and this is a month after the procedure. This is mitral clip. The heart is reduced inside, and there's no more heart failure, and right pleural effusion is gone also. The initial experience of using mitral clip in this patient, in HOCM patient. This is a report review from Cedars-Sinai group. They included the patient, 15 patients from 4 studies. You can see the LVOT gradient is down dramatically from 40 to 100, and after the procedure is only less than 20. And also the MR severity came down to 1, 0 or 1 in most of the patient. And the NYSA class from the baseline is most of the patient has a class 3 or 4, and after the procedure, the NYSA now is a 1 or 2 only. The patient has improved both symptoms and LVOT gradient and also the MR. The advantages of using the mitral clip in HOCM patient, because there is the ability of the real-time assessment, because you can see the hemodynamic change during the procedure, because this is a heart beating procedure, and also you can measure the immediate improvement of the cardiac hemodynamic parameter like a gradients and also the MR reduction before you release the clip. And this is a less invasive procedure than the septal myectomy, and maybe for less invasive than alcohol septal ablation also. This is not the coronary anatomical dependent compared to the alcohol septal ablation, and risk of permanent pacemaker is lower than through procedure above. However, the long-term outcome of using the mitral clip in the hypertrophic cardiomyopathy patient are required. Back to our case study. Because the patient has a fail of the P3 and also the SAM at the A2, the valve area is very small, just 3 square millimeter. We cannot use 2 clips in this patient. So we send the patient for septal myectomy and MVR. This is the intra procedure TE before the myectomy. You can see septal kissing right here and make the LVOT obstruction. This is after the myectomy is quite dramatically improved. No more the LVOT obstruction. And the gradient before was 50, and gradient after the myectomy was only 16 to 18. The transthoracic echo was performed on next day. The peak LVOT gradient was only 8, and patient rapidly recovery, and she can go home in a week. This is my decisive algorithm for the patient with a who come with a MR. If the patient is less than 65 and low surgical risk, I would send the patient for I was looking for the intrinsic mitral valve surgery. If yes, I will send the patient for myectomy with a mitral valve surgery, repair or replacement. If the patient has no intrinsic mitral valve surgery, the patient will undergo myectomy alone. If the patient elderly or high surgical risk, if the septal anatomy feasible for alcohol septal ablation, I would do the alcohol septal ablation first. If LVOT gradient is gone, but MR is still significant, I would do the mitral clip after that. If the septal anatomy is not feasible for alcohol septal ablation, I would consider mitral clip in this kind of patient. In my conclusion, the aim of treatment of SCM patient is to reduce LVOT obstruction and degree of mitral regurgitation. The systolic anterior motion of the mitral valve play an important role in the SCM patient, causing the LVOT obstruction and MR. The septal reduction therapy has been shown to be effective in reduction of LVOT gradient, as well as the improvement in the functional capacity of the patient. The concomitant MV surgery should be performed in the patient with the SCM and the intrinsic mitral valve disease, or inadequate myectomy, or adequate myectomy cannot be achieved by surgical technique. The alcohol septal ablation is effective and useful in poor surgical candidate, but it carries some risks like arrhythmia, heart block, or even sudden death after the procedure, and should be considered in the elderly patient. And the novel therapy like a mitral clip is potentially effective in reduction LVOT gradient and also the MR reduction. But we need a long-term outcome study for this therapy. Thank you very much.
Thank you, Dr. Mimuk, for your excellent lecture and covering all aspects of the outcome and MR. And do you have any other panelists have any opinions or question or comment for his lecture? Yeah.
I have I have two congratulations for your excellent talk. I'm totally agree with you, because as a surgeon, I always perform the extended septal myectomy. But when patient, the intellectual system is not so large and the mitral regurgitation is severe, I will perform septal myectomy and mitral repair for this patient. And the technique I use for mitral repair is FVL stitch, just like the mitral clip. So I do believe that the mitral clip will work in patients with HOCM and severe MR. I totally agree with you.
Thank you.
Yes. Great lectures and great discussion for 2 hours and 15 minutes. Yeah, it was a very great time that we could fully review from basics to imaging and intervention and surgery of the mitral valve disease. And it was a great time. And can I ask Dr. Su for the closing remark for this great session? Yeah.
No, I think the professor can do the closing remark. Yeah.
Okay. And thank you for joining APSC webinar, cloud webinar for mitral valve disease. And please join the next webinar, maybe about the aortic disease again. Yeah. Thank you. Thanks so much.
Thank
Bye.
you.
Yeah.
Thank you.
Stay safe,
you.
everybody.
Bye-bye.
Bye-bye. Bye.
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 让它掰完再关，掰完再关，然后就
Thank you so much.
最后一个走。对，可以了。